welcome to Conversations in Interventional Cardiology. My name is Andrew Goldsweig. I'm Director of the Cardiac Catheterization Laboratory and Cardiovascular Clinical Research at Bay State Medical Center in Springfield, Massachusetts. I'm also an Associate Editor of SCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent SCAI and our Editor-in-Chief, Dr. Alexandra Lansky, today. You can find us online at jscai.org, jscai.org, and on X at myjscai, at myjscai. JSCAI is home to all official SCAI documents and to a number of very important papers that move the field forward. We're here today to discuss an important recent publication in JSCAI entitled Understanding Right Heart Flow: Implications for Interatrial Shunt Device Therapy in Heart Failure. We have an esteemed panel of internationally renowned experts joining us today. First, we've got the first author of this paper, Dr. Raviteja Guddeti, a structural heart disease fellow at the Christ Hospital in Cincinnati, Ohio. We also have the senior author of the paper, Dr. Santiago Garcia, who's director of the Cardiac Catheterization Laboratory and Interventional Research, as well as the Structural Heart Disease Program at the Christ Hospital in Cincinnati, and also an investigator in the ALT-FLOW trial. We've got Dr. Megan Coylewright, a structural heart interventionalist, a clinical trialist, and editor of the American College of Cardiology's CardioSmart Patient Voice Program. Dr. Sheldon Litwin, professor of medicine at the Medical University of South Carolina, a reduced LAP-HF trial investigator as well, and Dr. Peter Fail, who's director of the Cardiac Cath Lab and Interventional Research, as well as the Structural Heart Disease Program at the Terrebonne General Health System in Houma, Louisiana, and also a reduced LAP heart failure trial investigator. So a fantastic panel. Welcome to you all. Thank you very much. We'll begin by directing a question to Dr. Guddeti. In this paper specifically, your work on right heart flow dynamics sheds new light on how interatrial shunt devices can optimally decompress the left atrium to improve heart failure symptoms. I wonder if I could ask you to summarize your group's findings for our listeners. I know that you prepared some slides.
Absolutely. My name is Raviteja Guddeti. I'm currently a structural heart disease fellow and interventional cardiologist at the Christ Hospital. On behalf of all the authors, I would like to thank the leadership of JSCAI for giving us this opportunity to present our findings from our paper. Before I jump into discussing about normal and abnormal right heart flow patterns, I would like to briefly discuss about therapeutic interatrial shunts and CHF. Elevations in LA pressure is central to the CHF pathology. And in fact, 90% of patients who present to the hospital with heart failure symptoms have pulmonary venous congestion noted in the findings. Interatrial shunt devices reduce this LA pressure by shunting blood flow from the left atrium to the right atrium. There are multiple technologies currently being investigated in early feasibility trials and phase 3 trials, including Corvia, Vive, Ventura, Occlutech, and Apture. However, preliminary data from all the trials and studies so far showed mixed results. We believe understanding abnormal and normal right heart flow patterns may be important or crucial in understanding how these devices work and what kind of effects they have on the right side of the heart, and also may be helpful in patient and device selection. In a normal heart, blood flow through the cardiac chambers is very well organized so that maximal efficiency is achieved. If you look at it here, blood flow from the caval veins is directed into the RA in a rotational clockwise vortex formation. And this rotational nature of the vortex preserves the momentum of the blood flow and also the kinetic energy, and also minimizes turbulence. This in turn leads to efficient transfer of flow and energy to the right ventricle. In fact, if you look at it here, the posterior wall of the right atrium and the inferior vena cava actually contribute predominantly to this vortex formation. And blood flow going from RA to the RV. The RV diastolic filling is dominated by slow, smooth transmission of blood flow from the inflow of RV to the outflow in an asymmetric vortex formation that was created in the RA. In fact, 44% of the blood flow entering the RV in diastole is directed to the RVOT and leaves the RV in the same beat without much contribution from RV systole. Using 4D flow MRI patterns, Fredrickson et al. Determined 4 different flow patterns in the RV: direct flow, retained flow, residual volume, and delayed ejection flow. On the right, you can see the path line visualization of MRI. The blue is depicted as a direct flow pattern. So coming to what are the disruptors of this right heart flow patterns? Some of the common conditions associated with this disruption include LV dysfunction, pulmonary hypertension, tricuspid regurgitation, and ASD. Coming to LV dysfunction, which is by far the most common reason for RV failure or RV dysfunction, studies have shown that there is significantly reduced direct flow of RV and significantly reduced kinetic energy of this flow component. And the flow overall in the RV becomes disorganized. You can see this left side video here. This is a patient with a normal subject. On the right side, this is a patient with chronic ischemic heart disease and dilated LV. And you can see how the flow pattern is well organized with the direct flow contributing to most of the flow. But here on the right, it's more disorganized with direct flow component being reduced. At the same time, you can see more yellow and blue, which is the retained inflow and the delayed ejection flow. Changes, this is a 4D MRI, flow MRI. Compared to a conventional MRI or echocardiographic indices, these changes actually proceed much earlier than structural changes. And then this image here shows RA vortex formation, the flow within the RA, vorticity, and also viscous heat loss in a healthy control compared to patient with HFpEF, pulmonary hypertension, ASD, and tricuspid regurgitation. If you notice here, there is well-organized flow with minimal vorticity and minimal viscous heat loss. In a patient with HFpEF, there is slight increase in turbulence, increase in vorticity, and increase in heat loss, viscous heat loss. But these changes are way exaggerated in patients with pulmonary hypertension, ASD, and severe tricuspid regurgitation. You can see how the flow is very turbulent. There is a lot more viscosity, vorticity, and a lot more viscous heat loss. And preservation of this vortex in patients with left-to-right shunts without septal defects. This is an example of a patient with unroofed coronary sinus where there is shunting of blood flow directly from the LA to the coronary sinus. The flow still follows the natural pathway, and there's not much turbulence seen in the images here. On the right, this is the patient with scimitar syndrome, the large subdiaphragmatic pulmonary vein draining directly into the IVC. Again, still following the same natural pathway for blood flow without much turbulence. And coming back to therapeutic interatrial shunts in heart failure, there are several unanswered questions when it comes to this particular therapy in heart failure. Number one is, who are the patients that benefit from this interatrial shunting? Is this a device or is this a therapy for every patient with heart failure, or are there certain patients who benefit from this more than certain other patients? Most of the studies in general have excluded patients with RV dysfunction, severe pulmonary hypertension, and tricuspid regurgitation. In fact, the recent RELIEVE HF trial using the V-wave have shown beneficial effects in patients with HFrEF, but there is a small signal for harm in patients with HFpEF. So there is a lot more need for identifying who are the ideal patients. Number two, is there a role for advanced cardiac MRI, like a flow MRI, 4D MRI, in patients before and after placing an interatrial shunt? Will that shed some light on the pathology or how these devices work? Actually, the ALFLOW 2 trial has a sub-study including 4D MRI. So hopefully that information or evidence will shed some light on this particular question. And lastly, what is the optimal location for interatrial shunting? Does location even matter? Corvia, V-wave, and Occlutech devices, they are considered direct interatrial shunt devices compared to Archer, which is more of an indirect interatrial shunt device, shunting blood from left atrium to the coronary sinus. In terms, we assume that The Aperture device still allows blood flow to take a natural pathway from the coronary sinus to the right atrium, rather than interfering with vortex formation by creating a direct shunt. Again, at this point, it's still theoretical. That's what we believe. Lastly, examining these abnormal flow patterns in naturally occurring intraarterial shunts can shed some light on how these devices work, especially in heart failure management.
That's fantastic. Thank you so much, Ravi. Really thought-provoking. The physics of it, hugely important as we look forward in the future to understanding how best to move blood from one side of the heart to the other without disrupting normal flow patterns.
Right.
I want to ask some of our panelists here about how this knowledge, and more broadly, how interatrial shunt devices in general fit into the interventional cardiologist's workflow. Maybe I can turn to Dr. Litwin and Dr. Fail, who've been looking at these interatrial shunt devices for a while now. How do these devices, or should these devices, fit into the interventional cardiologist's toolbox? And how should we change our practices in terms of patient care and selection and monitoring?
Yeah, I think the issue we're having right now, obviously, is looking at, reduced lap 2 was sort of a flat study in its cohort. And then obviously we're now into the responder study, looking at a more select group. I think that interatrial shunting, the things that I look for in HFpEF is intra-atrial shunting sort of the answer or the panacea for everything, and I don't think it is. I think it's going to be a subset, and I think this MRI study may help us identify those patients who would probably be better suited for shunting, whether it's interatrial or if it's going from the left atrium into the coronary sinus. But I think we still have a lot to learn. My infantile knowledge of the RV, I think, is really what gets us in trouble. I don't think we understand the RV very well. I don't understand. We understand the coupling between the RA and the RV and the pulmonary hypertension or the pulmonary circuit. And I think that's what this study helps us see a little bit more data in flow characteristics.
Got it. Dr. Litwin?
Yeah, so I think it's a great question, and I agree. I think most of the patients that I have been involved with shunt implantations have been HFpEF. We were also involved in the RELIEVE trial, so I've done some HFrEF. But the key seems to be picking the right patients, and at least in the HFpEF world, there are three main things that contribute to exercise intolerance, and that's chronotropic incompetence, the abnormal rise in wedge pressure during exercise, and the inability to augment stroke volume with exercise. And so, this therapy is only going to target one of those three problems. It's only going to be the excessive rise in wedge pressure. And I think that, we all are worried that over the long haul, that any left to right shunt may worsen pulmonary hypertension or RV dysfunction. So, in the best of circumstances, these shunts would have very little shunting at rest. So there'd be a small pressure gradient between the left atrium and right atrium, but they'd be able to respond during exercise. And so this would act as a smart therapy that delivers a treatment when you need it and doesn't do anything when you don't need it. Unlike diuretics, which work all the time, and for the patient that has normal filling pressures at rest, it's just going to make them dehydrated and or orthostatic, and it's just not going to, most of the time, it's going to harm them more than it helps them. So the shunt has the potential to be like an insulin pump instead of giving long-acting insulin, if we pick the patients that are most appropriate for it. And so, I think this idea of using 4D MRI to learn more about the process is fascinating. It may prove to be helpful. It may not. We'll see. And I think we're not going to only have to look at the flow in the right atrium, but I think the flow in the left atrium and how the flow comes out of the pulmonary veins, how it's directed across the shunt. And so, if you kind of think about like a river that flows and has rocks in it, and has streams that come in from the sides, and ultimately pressure gradients are what drive blood flow. but there's clearly more to it than that. And so it's geometry and it's shape and it's velocities and stuff. So I think the MRI can potentially have, huge amounts of learning opportunities for us. And we just need to start figuring out how to use it. So one last thing I want to say is that even though the trials both relieve and reduce LAP2 have been neutral, I'm convinced that this therapy will have a role and does have a role. I just saw my very first patient that I enrolled in reduced LAP1 8 years ago, and he is doing fabulous. I mean, he is so much better than he was before he got his shunt. And I've seen, I've enrolled, I don't know, probably 40 patients in various shunt trials now. And so I've got enough experience with this to really be convinced that it really does work, at least in selected patients.
Great. Well, I think both Dr. Litwin and Dr. Fail raised important points about what we know and honestly what we don't know in this field. It's a field of great promise. Heart failure is obviously a very common disease, a very challenging disease to manage, and interatrial shunt devices are certainly a very hot topic in the field right now. I wonder if we could turn to Dr. Coylewright here, who has a tremendous amount of experience with clinical trials, and ask you if you could take us through really briefly what is in the pipeline now. What are we looking at? What are the possibilities? What devices and trials?
Well, Andy, I think that's a great question. And I might, for the audience, just take a step back first, because all of us here on the seminar have been thinking about this for a long time. But I think a quick review of where we've been helps us understand where we're going. So we mentioned the two major randomized sham-controlled pivotal trials, Reduce LAP2 and then Relieve HF. And they were really different from one another. So I think I cannot agree more with the statements about patient selection being critical. And it reminds me of our journey in cardiac resynchronization therapy, where it took us a long time to identify the patients that benefited. But now it is such a powerful therapy for those patients who we know that can derive some benefit. So I think this is analogous, and it does require some faith. When you have a study that demonstrates either neutral or in subgroups the potential of harm, people were worried. It's so important to keep enrolling in these trials because we're starting to become closer and closer to that group that will really benefit. And so the Reduce LAP2 trial helped us understand an important responder group. And that was a group that when they exercise in the cath lab, they develop pulmonary hypertension. So that core group of people are not included in most of this upcoming studies that you're just asking about. They also identified that those that have pacemakers or other rhythm management devices also did not benefit, so they're not included anymore. And so although you mentioned Oclatech and our Frost HF trial, which I was the national PI on, that trial is no longer ongoing. After Reduced LAP2, we had decided a couple things. We included those groups and we weren't doing exercise hemodynamics. So that study's waiting for the next round of results. And now, in full disclosure, I'm on the executive steering committee of one of the no implant shunt trials. So that's the Allay HF trial, which is another pivotal randomized sham-controlled trial. Patients don't know if they got the intervention or not, but is unique because there's no device left behind. And the mobility of the septum perhaps could be important in some of these hemodynamics. And, imaging studies like the one presented today might help us understand that. So for your question about what's to come, well, the devices are all different. So some of them are in the intraatrial septum, some of them are LA to coronary sinus. There's a number of strategies that leave no device behind. The only one that's in a pivotal trial right now is Allay HF, Alleviant's mechanism. But there are a lot of people that are interested in this space. But, look, the most important thing is identification of the appropriate patients. And here's the kicker for those interventionalists of us that are on the call. And that is we have begun to understand that exercise hemodynamics really are essential in this field. And I think Some of us groaned at the beginning, like, I don't know. When I'm asked to do a right heart cath, I don't know if I want to do that. Now I got to put him on a bike. But this is a really powerful diagnostic strategy to identify patients to benefit. So I think that'll be a neat thing to hear from others about, when we talk about training and the next generation, how that's going to fit in.
Fantastic. Well, thank you for that summary. It's clearly a very broad topic, and you masterfully condensed it into a digestible form. On the subject of training, as you point out, I want to look at Dr. Garcia, who is sitting here in the upper left-hand corner of my screen. You're not only the senior author of the present paper, but of course you're also Dr. Guddeti's training mentor. General cardiology, interventional cardiology, heart failure, structural heart disease, there are so many areas that can be touched by this therapy potentially. I wonder if you could comment as a fellowship program director about how this information, right heart, function, interatrial shunt devices might be incorporated into training. What information do we need to get out? What skills do we need to teach?
Sure. Let me first start by acknowledging Ravi, who did a great job with the presentation, and the JSCAI editorial board for accepting the manuscript and giving us the opportunity to discuss the key findings in this expanded format. I would also like to acknowledge our co-investigators, our imaging colleges, in particular, Pankaj Gar, Joao Calvacanti, and Marcos Carson, who did all of the heavy lifting with the imaging that you've seen today, and more to come with the paper. They are the ones who deserve a lot of credit for this work. I think to answer your question, the message for the fellows in training is at this point, just keep your eyes open and stay engaged in the field, because interventional heart failure is a rapidly moving field that has the potential to transform how we treat one of the costliest diseases in the United States. It requires a different mindset. One that not only focuses on the technical aspect of device implantation, but also on the new physiologies that are being created by these devices as a consequence of our therapeutic interventions. I think when it comes to right-sided interventions, we tend to think in terms of restoring physiology, replacing a tricuspid valve, repairing a tricuspid valve, for example. But these shunt devices actually create a new physiology, one that needs to be fully appreciated and understood before we march forward. And I think that was the attempt of this manuscript, try to understand normal and abnormal physiology as it relates to these devices. As you mentioned, Andy, there are multiple subspecialties that will be affected by these technologies, from heart failure to general cardiology to interventional. So I think it's important for all the fellows to be engaged at this point and follow the literature, because this is one, I think, piece of technology that could potentially change how we treat heart failure in the future.
Fantastic. Well, it is certainly a brave new world in terms of the possibilities that this therapy offers. So thank you not only for sharing this particular piece of knowledge, but for helping to train all of us in this growing field. We're nearing the end of our time, so I want to say a big thank you to Dr. Guddeti, Dr. Garcia, Dr. Coylewright, Dr. Litwin, and Dr. Fail. We are thrilled to publish this important document in JSCAI and to share the discussion with this incredible panel. Please follow JSCAI. Submit your own work to JSCAI. JSCAI is the official journal of the Society for Cardiovascular Angiography and Interventions. You can find us online at jscai.org, jscai.org, and on X at myjscai. Thank you all very much.